I'm going to be joined up here. You're not just going to hear from me for the next hour of your lives. By three, I'll use the word luminaries. You can make your own judgment call by the end of the hour, as whether that's the case or not. So we'll start off with Matt, who's going to join us from Microsoft. So come on down. Okay. So Matt is the CMIO at Microsoft Nuance. He's an interventional radiologist. He actually practiced here and still does continue to practice as well. He's based over at Microsoft, and very pleased to have him here. We've got Renee, who's going to join us from NVIDIA. So Renee oversees about 4,000 startups in the ecosystem around NVIDIA, around generative AI. So I'm glad she's here. And last but by no means least, Patrick's going to join us as well from the American Heart Association, where he runs, what's the actual official piece of the AHA that you run?
Center for Health Tech and Innovation.
There we go. So, three luminaries, and I have my little humble offerings to bring in as well. And I thought, I was listening to Ramesh, and I'm minded that this space is complicated. You know, a year ago, we were all sat here and, you know, maybe, I'll say most of this room probably had heard of a thing called a GPT, most of this room. But most of the public had absolutely no idea what the heck we'd be talking about. And we've captured the imagination of the public in a way that, well, no one has since, those of you who remember Stanley Kubrick with 2001: A Space Odyssey. No? Okay, well, if you haven't seen that, go and see that, okay? That was a scare the bejesus out of you. But, so now we actually have a public who has expectations. They have expectations that are set by their experiences, expectations set by what the media is telling them. Instantly, all disease will be cured because of this, okay? But I was listening to Ramesh, and I'm minded that there is many, many different facets here. And to paraphrase David Bowie, if it works, it's out of date. And nothing could be truer when we're talking about generative AI. So I'm going to ask these three people a series of questions, and we're going to riff around them as well. I'm going to riff off their answers. And if there's something burning that you think we're missing that we need to get out, I will take an audience question as well. Just one, so make it a good one. What excites you about where generative AI is going right now? And we'll start with Patrick.
Well, thank you. I think in several areas, and building a little bit off what Ramesh said, we still believe that the patient in many ways, or the consumer, is the greatest untapped resource in the healthcare ecosystem. And the reality is that the potential for these solutions to enable patient self-actualization, to meet people where they are in terms of their health literacy, their health numeracy, and guiding them and educating them across what is, in many instances, several disease states and issues, helping them with complex problems, and also as they run into the medical industry, to learn this new language of what they're dealing with in healthcare can be very confusing. The tools that allow them to capture this information from these periodic encounters with the healthcare system, to understand and interpret that, to ask good questions next time around, to consolidate data, to build more data through smart wearables and biometrics is really exciting. And Ramesh talked a little bit about this notion of a chat bot, a friend, administrator, right? An entity, an omni-channel entity that can essentially work for the patient behind the scenes. And the reality is patients and their families do this to a certain extent together. And so there's learning opportunities for the family as well. And that is a teachable moment. In many instances, the family members may be dealing with these issues down the road as well. So we're excited about that potential. There's certainly some other areas on the other side of the AHA's business, which is more about discovery of science and what have you. But this patient element is really exciting. And I think it's very fresh and very much enabled by these new technologies.
Thanks, Patrick. But as we're doing that, that brings about risks as well. Yeah. And it brings about things we have to be increasingly concerned about. So, Renee, as you look, not only here in the US, but broader internationally, now, what risks do you see surfacing and being addressed? And what risks are still out there that aren't being addressed?
I think globally, the one is geopolitical sensitivity. Obviously, this is out there. And then the data sensitivity ethics of how do you collect the data, how do you store it, how do you share it, etc. Is another big one. And also some of the risk and challenges definitely comes in the computing aspect, depends on how much compute you need for training and inferencing, and do you actually have the supply to be able to reach the high demand out there? And the question for many of the startups in the audience is, do you need that much compute for what you're doing, or is there an easier way to do that? So I think there's definitely a lot of risk out there. And then on top of that, one of the old problem of AI explainability continue to be a big problem in the generative AI and large language model era, if you can call it. Yes.
So thanks. And as we're going through embracing that risk, I'm minded that there's other technologies that actually sit around generative AI as we're adopting and as we're mitigating. And some of those are ones that you're familiar with around ambient technology, et cetera. Matt, how do they play in here? And both to manage risk, but also to manage trust?
Yeah, I mean, just a quick point. I was hoping we'd have a NVIDIA H100 in our goodie bag. Is useful? No? Did anyone get one?
We can ask.
Okay.
We might have something
that would be great.
for the winners.
I was really, really hoping. So I think this is a fast evolving space, and I think there's a few different ways to tackle this. I mean, the very simplistic way to look at this is risk versus value. And there's a lot of things that were covered on this slide. There's things that I think about. Every clinician in this room has a million things that they can think of that this technology can enable for them. And I think we'll get there. But I think for right now, even with some of the things like grounding and RAG and some of the capabilities that we have around guardrails, all the ways that we try to make these things more safe, we still spend $600 billion a year in administrative tasks in this country on healthcare. $600 billion. It's a pretty big market. And so when I think about where GPT is going to enable all of you in your day-to-day lives, your co-pilots in your Word and your Excel and your Outlook, you're going to start becoming really familiar and maybe more efficient in your day-to-day life. And then for those of us who work in healthcare, when we go into our practices and we have software applications that don't make us efficient or as efficient as we are in our daily lives, I think there's going to be a bigger gap than ever. But a lot of those tasks, in fact, you talk to most physicians, I don't want to hunt and peck through the chart. I don't want to have to redo the same order set over and over again. There's simple things that we do in our day-to-day that you can massively improve for us without getting us into a place where there's not a human in the loop. We're automating with several agents. We're chaining too many prompts together, and we're getting over our skis. I'm not here to say that none of those things are great and useful, and I hope that we see a ton of innovation because we need it. But right now, we have a big task in front of us. We have 50% plus of physicians looking for the exits. And that's just physicians. Nurses are a big part of this as well. We don't talk about them enough. And we cannot have a healthcare system, no matter how optimistic we want to be about our capabilities, if we don't have people to serve our patients. So again, I'm laser focused on what you would call the boring things in healthcare, because I see that they provide a great deal of value with a lot lower risk.
That's right. And we're going to come back to administrative burden in a little while, I think. But so we all see a bright future. We get that. We're not quite sure what that future really looks like. And we recognize that there will be some false dawns as we go along that way. But Renee, what do you see, given especially the startup ecosystem that you have around you, that are the largest challenges that they're having and that frankly people in this room are also having when it comes to adopting a technology hockey puck that is still moving across the ice rink? I'm great at mixing metaphors, by the way.
Just throw some sports in there.
If I could say one word, it's probably differentiation. But let me set some context, because a lot of people probably in the room don't even know what NVIDIA does and why is NVIDIA on a healthcare panel. NVIDIA is a GPU company, but we also is a full stack company. We built both the hardware and also system software and libraries and the application framework. So the entire full stack approach ended up enabling about 4,000 healthcare life sciences startups in our ecosystem, because many of them can join us at any different stages of their journey. And with that, we primarily focus in 4 different areas, which is really important because then you know the comments that I'm going to make is within that context. If you're outside of that context, maybe this does not apply to you. So the areas that we focus on is medical imaging, a lot overlapping with what Matt here is doing, and a lot in genomics, drug discovery, and a little bit of a digital health. And this digital health world is quite of a mix of a lot of things. So anything that's related to large language models for text-related solution definitely comes in here. But we also see a lot of smart hospital-related solution like robotic surgery, etc. Like med device solution also fall into this large bucket of digital health. So in this area, I just came back from health conference at Vegas last week, which is a complete candy store for me. I went to visit almost every single booth and then just to see what they're working on. A lot of people are trying to do Microsoft Copilot. Many of them are. So in fact, I went to ask them, so how are you guys different from what you're working on? I would say the answer was not what I expected. Many of them sound somewhat the same. They're like, well, we have our proprietary large language model plus open source large language models, whatever we can combine, and then we got a unique data set, and we have all of these great people in the market that's going to take us to execute and then be able to deploy it into 20-some health system, and some of them like, we're already in 100 hospitals, we're serving 200 million users. Differentiation is going to be somewhat a key in the future. So they all sound somewhat the same. Every single one of them got their data, their infrastructure, and the large language model approach, and who's who in the zoo and the deployment, lock and loaded, EMR integrated. I was like, okay, they really do sound the same. So at least from the startup ecosystem, in this large digital health bucket, I see huge challenges because you literally can have a company in 4 hours now. It's pretty amazing. So I think that the startup ecosystem, if you're going to get funding in this actually all-time low environment right now, that key differentiation is going to be very important.
Thanks. So, okay. So stepping slightly to one side, but still embracing some of those concerns. As clinicians, we know that we practice based upon negation. That's the fundamental essence of the consultation. Whereas the essence of GPT is to match upon probabilistic matching. Okay? Those are two contrary motions in thinking. And so with that in mind, and as a startup organization trying to make my way in this wonderful, muddied, heterogeneous world of health IT, how am I, Patrick, just so you get queued up for this, how am I going to start demonstrating that what I'm doing has quality and it's leading to better outcomes, it's leading to improved experience of care delivery, both for patients and providers, and it's also leading to better access to care? Any of those three would be good, but all three would be fantastic.
Yeah, no, thank you. Great questions. And, you know, building a little bit off the way Renee framed what she's doing, in our world, in our Center for Health Tech and Innovation, we're essentially working with digital health and health tech companies and modeling our science. We just call them digital care plans, daily, weekly, monthly plans of care in heart failure, AFib, cardiac rehab, stroke rehab, hypertension, several other conditions. And we're essentially infusing that software, if you will, that digital science up and through relationships with these companies. And to your point, working very hard with them to design digital clinical trials and studies to understand exactly what's going on through use of their technologies, which we don't own and control, but infused with our science and guidelines so we know it's evidence-based. And then taking them down this natural path of the sort of combination of health economics, as you said, and health impact, and showing that there's really a distinction. This is one of the ways we can help startups differentiate. We have about 50 companies in a collaboratory, and again, we just call it an innovators network. But fundamentally, we only cover so many topics, and the health industry is much bigger just than cardiovascular and stroke. But in our corner of the world, we're going to do whatever we can and work with whatever entities like HealthUnity and others that we can to try and get to this cost and value and access point of view that you described.
Thanks, Patrick. So Matt, maybe, going back to your earlier point around administrative burden, maybe the way of demonstrating quality is actually to stay away from the clinical outcomes and to focus upon actually how we can focus on the experience of care delivery from providers, reducing that administrative burden. Does that sound rational?
Yeah, I mean, there's, so Nigam Shah from Stanford did a ton of work on this in what I would call the pre-LLM days, but a lot of those findings are still relevant. And so looking at your model or your solution, a lot of times there's 400 now FDA approved alone. And you kind of say, well, is this a productivity thing or is this an efficiency thing? And then how good is it, right? We have pretty good frameworks, I feel like, in the pre-LLM world. But then what we failed to do, and this is all of us in the community, I think for many years, as we built these things and deployed them, we didn't look at what decision was going to be made as a result of that being right or wrong. And then we didn't look at what the capacity of the system was to deal with that decision being made, right? There's a few steps along that chain, and we were so focused on super accurate models for a long time. Fast forward to now. Now we're in a circumstance where we have one obviously super model, GPT-4, that is obviously very much ahead of a lot of the field, but then there's a whole bunch of these other models. We don't have a good framework to even start to evaluate them, benchmark them. We use the USMLE. That is not realistic, right? That is not a realistic measure. It gives us some sense that there are internal representations of medical concepts that are grounded in reality, and we can manipulate and use those, and that's great. But that doesn't really help us for truly understanding the capabilities and the performance of these models. So that's step one, let alone now saying, how do I make decisions? Then how does my system deal with that? So again, by starting small and thinking about things that are documentation-based, things that are required. For example, there are nursing handoff documentation tasks that are required. We have to do them. And that is painful, it's extra work. Nurses get paid quite a bit per hour, and if they stay late to complete that documentation, they get paid double. So as a healthcare system, you can start looking at, well, I can look at efficiency and productivity and try to find the right spot on that curve and say, listen, that's nailing that part, but I still don't know if there's 15 different startups, how do I choose which one's the best? And that's sort of where I look to organizations like this, and I commend the effort here, because we really have to figure out what is that common language for me to say, well, listen, if I have a use case in this series of areas in healthcare, how do I know which one is going to be the best? By which judgment am I making that with? And it can't just be my marketing materials, and it can't just be because, oh yeah, I saved a few minutes. It has to be something real that we can use, and we're going to see so many of these proliferating that again, I encourage these kinds of efforts and others to really help us do that.
Thanks. So if we draw a big line between the creation of tooling which can assist with automation and tooling that can exist with augmentation, okay, so more human in the loop than human out the loop, is there actually a process by which people can sit down and say, hey, this is where we should focus our efforts. This is where I should be developing. This is where I should be innovating. And these areas I should step away from. Have you seen that?
Trying to cure cancer, maybe step away, just because there's a lot of things that we haven't figured out yet. So I agree with what Matt said. Some of the tedious problem is actually one of the first few problems to get in there and either augment or automate, and that's probably the easier low-hanging fruit. Then I think figuring that out where the money is going, definitely follow the money is a good tip for the startups. Then it's looking at your team. Does your team, what kind of talent do you have? Does your team actually have the raw talent to be able to really fine-tune the large language model, build the large language model, or maybe piggyback on top of large language model that's already exists, for example, if you want to go into the Gen AI space. And of course, all of that is preference on top of you already figure out the product, and you hopefully are very close to figuring out like product market fit, etc. So I would say that is an either or question. It depends on a lot of variables in that, but you don't have to solve the most difficult problem out there to get VC funding. You have to solve a problem where it adds value to the right group of customers or patients in this case.
Okay. We know there's no easy path here. So if I'm looking to innovate, Patrick, I'd like to herald you so you can warm up for an answer here. Infrastructure, applications, or data. Which of these three should I be focusing on? Which of these three should I be embracing more and solidifying around? Which of those three should I be saying, okay, someone else has got that?
Yeah, it's an interesting question. You know, if I think about it from a portion of the AHA, which is a very large organization, they would say data, you know, absolutely data, and thinking about how to map all this large data to think about future prospective studies, to improve the rapidity of the development of guidelines, to look and see what the data opportunities are, the health improvement opportunities are coming out of the EMR data and from the imaging devices that are out there, and identifying care gaps, gaps in care, and ways to get closer to ideal health wherever you are on that spectrum. You know, from our point of view, we tend to look more at the gaps. We say, well, what's happening in cardiac rehab? We know that 80% of people don't get into cardiac rehab that are eligible. This is a phenomenal opportunity to improve health and ultimately to lower costs, where there's already models and reimbursement in place. So to some extent, it depends which part of our organization we're talking to and which type of a startup. I will say, in the spirit of trying to solve the right problems, we're working and doing studies with our 16 scientific councils. We have about 35,000 professional members. About 15,000 are in clinical practice, and so are highly interested in this part of it, and try and see what problems they want us to solve across their areas and spheres of influence. So part of it is matching where we see the interest from our experts and where we see the companies trying to solve things and looking for those matches, right?
Thank you. So it feels that from many of the comments you guys are making that there's a trust part of all this. There's a trust from a provider, a physician, in the technology being used. There's a trust from a patient that their data is going to be handled appropriately. There needs to be a trust from developers that their applications are actually working upon the right foundational tech. There needs to be a trust that those are going to be taken to the market correctly. Who arbitrates that trust? Who is it who's actually going to sit in the middle of all this? These two are sitting here saying, thank goodness we didn't get this question, okay? Who is it who's going to sit there and say, these applications, these technologies are appropriate, that they're using data from patients appropriately, that they're creating factual information that can be used, and that they're relevant and doing what they say?
Yeah, I mean, trust is everything in healthcare. I don't have to tell this audience that. And there's a lot of concern, and there has been since the AI sort of wave really kicked off in earnest in the last 7 or 8 years in healthcare. Where's my data going? Who has access to it? What are they doing with it? We've all kind of gotten complacent, I feel like, in our daily lives with that, and I sort of, I feel like we're starting to wake back up as a society against the idea of where exactly is my data being used? Is it feeding some of these applications that are now being sold back to me? I think there's plenty of concern with that. I can say from the perspective of, a large cloud company, we are, sort of laser focused on trust and data security and not using customer data to train models, et cetera. I think, in fact, what we tend to think a lot about is how do we enable this room, clinicians, folks with new ideas, new use cases, with the tools to get up and running within an ecosystem that they can deploy in that already kind of has some of that trust built in. In other words, again, bringing another UI to a physician, bringing another application I have to click on my desktop, unless it's game-changing in a lot of different ways, it's going to be a tough sell. But if you can make something great happen inside of the applications that I use day-to-day already, totally different conversation, particularly if that trust is baked in, because there have been, obviously, plenty of software companies that we've built relationships with through the course of our careers. I think, going back just quickly, I think we've focused a lot with the things that we've talked about, and I don't want to assume that everyone in this room who is working on a new company is focused, and I think of the world as a stack, because that's what we do in cloud. And there's the base infrastructure, there's the data layer, which we kind of hinted at, but that's really important. I'm not convinced if we go towards what Ramesh talked to about, if that's our future, if we are going to interact with our health data as a dynamic entity, does that mean that I have to store it in the same way that I'm storing it now? I don't know. It sure is difficult right now, as you all know, to try to smash as much of this stuff into an embedding and stick it in a prompt. I don't feel like that's going to be the future. So who's going to help us decide what that future looks like? How am I storing multimodal data? Healthcare is multimodal episodic care, right? I don't have a context window sort of approach to think about that. I don't have enough agents to really handle all those different modalities in a convenient way. That's a pretty low down the stack thing to think about. So, again, I don't want to say that everything has to be a consumer level, top of the LLM wrapper, quote unquote, sort of application, right? We really do feel like there are huge innovations that will be made in healthcare that will start to move up the stack from the data layer, obviously the model we've talked about, and then clearly the application delivery mechanism. So I think, and again, underpinning all of that clearly is trust and who your partners are and how you're handling data.
So thank you. You managed to dodge the question really, really nicely.
Yes, I do.
And the answer, frankly, to my view, is that it's going to depend. It's going to depend massively upon the circumstances, the context that you're actually utilizing the AI. And at the end of the day, it comes down to us as providers to actually say, I trust the tooling that I'm using. Okay, but you raised an interesting point there, Matt, around, and I opened it up with it slightly as well. We wouldn't be sat here today if the media hadn't caught hold of this thing called ChatGPT. Okay, frankly, would have been a very small room with no windows, with a very small group of people who are really interested in the deep math behind us, which may have included us lot as well. But it's that human nature of the interaction. And we were talking at lunch around, it's a false empathy. Okay, machines don't really care about you. Okay, much as you like to think that your iPhone or Android, sorry, let's be politically correct, your phone actually loves you, it doesn't. It doesn't care who you are. And neither does ChatGPT. It knows you as a probabilistic equation. And so with that in mind, have we got an opportunity here, Renee, to break down some of the real barriers we have in healthcare? As Ramesh said, healthcare is broken. So this false sense of intimacy with a very well-read machine, is that actually the opportunity we're waiting for to create the more personalized nature of healthcare by impersonal means?
That's a complicated question.
It was a very complicated question.
I have seen use cases where, obviously in mental health and a couple other places where actually machine has done a little bit better to be quote, quote, more human than very burnt out physicians and healthcare professionals that don't have the time to respond in a very caring way. And I have seen some of the startups are targeting specifically, let's say, mental health is a taboo subject in a certain population. They want to go in and leverage machine to talk to these people who don't actually want to talk to another person because they just don't want to be maybe associated with knowing that they have some sort of mental health problem. Even though honestly, I comfortably can say 100% of us in this room have some sort of mental health problem, which is on a spectrum of 1% or maybe closer to 100.
That's right.
So if we pay to go to the gym, we might as well pay a little bit to exercise our brain. So I think conversations like that, we start seeing that where technology, even though they pretend to be caring about human, actually do add some value, because there are some sensitive topics that human will prefer actually to talk to a machine.
Yeah, and we spend such a tiny percentage of our time in front of providers or even allied care, and the reality is then there's fewer and fewer, more of us, and we're sicker and sicker and living longer, and I think it's just going to be a time issue as much as anything else. And it's interesting too, to your point, the number of studies as people communicate with avatars, for example, for purposes of checking in, for their appointment or follow-ups over time, they're much more expressive to these entities. They say more, they talk more about their issues. They share family member information, and it's a very interesting dynamic that occurs, particularly over time. And it's a fascinating, as you say, there is no empathy there, but it's sort of false, but it's true at the same time. So I do see that there's some value in going down this road if done properly.
I want to say one thing about empathy.
Go ahead.
You probably all remember the paper from UCSD that talked about physician versus chatbot responses to.
Yep.
Right. Okay. And the machine was judged to be much more empathetic. Again, we could quibble with the methodologies there, but nonetheless, I think that there is some valid reason to believe that the response sounds more empathetic. But to me, it's not necessarily the empathy that I'm interested about with a result like that. I'm actually more interested in the fact that it tells me that just like the model can manipulate concepts in healthcare, it also understands context. So if you think about the task of, I'm just going to name an ambient note generation tool without promoting anything.
Did you know any of those?
Yeah, I may have heard of one. But just really, it sounds really simple and boring. Like you're just going to transcribe a conversation between a doctor and a patient, and you're going to turn that into a note. That sounds like we should have been able to solve that in NLP 6-10 years ago. But if you really think about the problem, it's way harder than you think. Because in that conversation, I'm going to talk about my vacation, I'm going to talk about my cousin's wedding. I might say I was on a dose of 10 milligrams. I think, oh no, it was 20. And that's all going to be transcribed. And you have to take the right context out of that note to understand this. Now, empathy is about context. And so that's where that tool or that skill, that emergent behavior, has proven incredibly valuable for applications like that. So I wouldn't just say empathy is just on the behalf of the interaction with the person. It's actually useful as a tool as we think about building applications in the healthcare ecosystem, because empathy is context, and context is critical.
Thank you all three, and thank you for chiming in, guys, as well. I think what's important there is, though, that when you do those transcribing using these generic toolings, whatever they are, it's not just the transcription tech that's there. There's a whole bunch of other tech that's being used which weren't created there. These are all composite applications, and that are built also on top of the standards. Now, because there are health information standards out there that we should be using, things like HL7, things like SNOMED, and more besides. So it's not a case of just going alone and building this in isolation. It's something you build in composite with others, and with other people in the room as well. As clinicians, we've been accused over the last, let's say, 20 years of overprescribing. Okay, it's a general thing, we see it all the time. This was another one of the lunchtime conversations, by the way. If you were at our table, you'd have had a fantastic conversation. Not that you guys didn't, but this was good. Is there a danger that we have with the adoption of increasing levels of sophistication in models which are generic by nature, that we end up with over-surmising? So we end up with, we've seen already, I think the New England Journal, where we had the hallucinations around orders which were being taken actually from a transcription, and around the hallucination with the wrong order and the wrong lab test being ordered. It was supposed to be a basic, and they actually went for something else. And is there a danger that the technology gets so accepted that the surmising that the technology creates gets taken as gospel? Patrick.
Yeah, absolutely. And there was a recent study, I think it was around CPR, where they asked all these devices, I won't name them, how to do CPR, which we're very interested in as the American Heart Association. We lead CPR training domestically and globally, and they all got it wrong to a degree. And but it all sounds good, and there you are, you're back to this notion of it's so accepted, who's checking, who's at risk, where is the indemnification lines, where are those going to line up? Is it the platforms, is it the tools, is it the middleware, is it the buyer beware all the way down to the patient consumer? Unfortunately, those things will play themselves out initially through business agreements, and then later to some extent in the courts, I suspect, and much will be written about that later. I mean, look at the problems we're still having litigation over telehealth, which seems very benign at this stage and so readily accepted post-COVID. But there we are with telehealth, and we see what unfortunately may be possible simply because in some respects it's so good and it sounds so great.
Yeah.
And we come to rely on these things, as we will over time, and there certainly is some danger there, there's no doubt.
I was with some senior clinicians in the UK recently, and one of them said to me, if I just entered everything that a patient says to me into ChatGPT, it would turn every single one of my consultations into an episode of House, because all I would be picking up would be rarity and things which just don't make sense in the context, because I don't have the context. So, as we start closing up here, there's a future for this tech. There's a wonderful quote from Forbes in the back end of the 19th century, or some of you might know it, and I'm definitely paraphrasing here, but it's basically saying that its form and fashion is alien to us and it will never be adopted because it's just weird. And that's kind of the point we're in right now. Now, back then, they were talking about the stethoscope, which arguably became one of the most important medical devices to be used, for the last 150 years. So I think we would be remiss to think that this is not going to be adopted wholeheartedly, okay? And it's going to be adopted because the health IT technology vendors out there are already incorporating it into their systems. It's going to be adopted because when I go into any organization here in the US, it's already being explored. When I go and talk to someone at OpenAI and ask them for how many login email addresses come from a particular organization, you'll find there's a very, very large number. So we know that people are using this tech. It's going to become de rigueur. It's going to become just the way we work. It's going to spread out to incorporate other tech as well. It's going to incorporate hyperreal. It's going to incorporate ambient tech. It's going to incorporate a bunch of other things. Where do you see in 10 years' time? Let's just say 10 years, because 10 months has changed the world here. But in 10 years' time, when we're maybe looking at other types of pandemic-y type disease coming along, other things, what's going to be in your world as you're embracing this technology, Renee? 2 sighs of relief, literally.
10
I felt
years? Come on.
It's hard. It's hard.
2 years is hard.
Yeah. There's a class at Stanford that teaches about how to be a futurist. If you guys haven't take that class, it's a pretty good one. Mainly in that class, they actually talked about it's actually easier to predict 20 years out than actually 2 years out. It's very interesting. They ask you to look for key indicators in the market and then combine them and see what may come of it to see if that may be a potential future trend in the future. So that's a very, very interesting class. I don't know if they still teach it. Okay, to answer your question, I digress because I need to think. 10 years out. I do think the patient-first type of a platform is going to more personalize, and precision medicine is going to become much more of a reality. Case in point, I was at a health salon with a group of healthcare professionals in the space. One of the patients, he is going through cancer. He is also a doctor at UCSF. And then for him, he actually said that as a patient, I'm a very privileged patient because I get to ask ChatGPT a lot of questions that my doctor actually can't even tell me. He was like, my doctor doesn't care about my health as much as I care about my health. And he's a doctor himself too. So he ended up did all sorts of research, including pasting his own gene sequence into ChatGPT to say, tell me what you find. And then he ended up finding certain mutation within himself that he needed additional help on. And he decided to, I forgot if he decided to go through chemo or not, but he ended up asking ChatGPT to say, which are the startups that are working on this specific mutation of my disease? And then he went to contact them. So he is a very privileged, knowledgeable patient in this space, but I think as we build better technology that's trustworthy with really great data, maybe Dr. Google's of the world is gonna be a new world for all of us. And all of us as patients, because that's going to be all of us in the room, can be in the driver's seat for our health.
Thank you, Renee. Pat?
I love that vision, and I think fundamentally it flips the script a little bit, right? As she played out this notion of people looking at their own genome sequences, looking at their healthcare, and making their own decisions, but allowing these systems to smartly work for them. Whether that be upstream in prevention, where we're already spending a lot of time and money without a lot of these smart systems to aid us and really see if these things are making a difference, all the way down to post-acute and end-of-life care. I think, to me, this kind of reversal, this movement towards consumer and patient-centered care, where truly patients and consumers and families are in charge and looking to the medical system for advice and support or surgeries or whatever it's going to be at the right times would be an ideal scenario. You did say 10 years. It is going to take a little time. But again, fundamentally, these technologies, if we work them right, if we use them correctly, have the ability actually to work for us. and do what the healthcare system doesn't do very well, which is look at the whole person and cut across a lot of these disease state areas and look at people holistically and determine how best to access the care system in order to get what's needed at the right time.
Thank you, sir. Wow.
All right. Yeah, 10 years is, in this sort of compressed time frames we live in is tough. So I worked here, I joined as a faculty in 2012 with someone named Sam Gambier. If you're familiar with him, he was the chair of the department. I remember I met him. He had two great quotes that are somewhat relevant here. One is, Matt, we've cured mouse cancer 1,000 times. We've never cured human cancer. That was the first quote. I thought that was really, really fascinating. But the second quote he said is, we just celebrated the opening or the ribbon cutting for the groundbreaking of a brand new hospital. We had a huge celebration. All these donors came out, and we had a big party. He said we should be celebrating closing hospitals, not opening them. And his point of view for both of those was that our priorities are really kind of out of whack. And sort of to both of these, with my co-panelist comments, it's really about how do we move towards that healthcare, not sick care idea. And I think that when I look at the large language model's relationship in this trajectory, which I think is the right one, it's a reasoning engine, it's a dot connector, it can take a lot of disparate voluminous information and bring that together in a way that I need to interact with, or give me exactly what I need to know when I need to know it. Connect those dots for me. So if I have all these devices, wearables, whatever I have going on, and I'm trying to do a home health model, today that's very difficult. Because what do you get? You're going to show up to your doctor and you're going to hand them all your data for the last 2 months, 6 months, whatever. How am I going to process that information and really make any care decisions, by the way, in a 15-minute visit? But now imagine you're in a world where you have somebody that can reason over that information. You can interact with it. The information asymmetry is reduced so that you're having conversations in natural language with that data. The physician can get that information quickly. Now you're starting to change the equation. So some of those things that we've dreamed about for so long, which is being able to monitor people at home, pushing care outside of the hospital walls. And of course, as we look towards cancer treatment, we can start to look at human causes and human disease models of cancer as opposed to animal models. So those are the two trends I see happening.
I like the way that you criticised my 10-year in the future by going back to 12 years in the past. I thought that was interesting. In closure here, we are in a very, very interesting, fast-moving place right now. 15 years ago, who in the room had a smartphone? Right? Now university adopted. With all the promise and the good things that come to us, instant access to information, may be right or wrong, instant access to call people, instant access to our mail, all that kind of stuff. Okay, also comes the bad side. So we have, people trying to crack into your phone, people trying to send you phishing emails, all that kind of stuff. I think we're going to see some of that now. Okay, we're going to start that ebbing. Again, the lunchtime conversation, which our table was just fascinating again. We were talking about the increasing use of generative AI for fraudulent claims creation. So we're seeing that. We're seeing it creating diagnostic quality images, which are fraudulent, and all that kind of thing. We're going to see that. So there's going to be the downside of generative AI as well, and the threats to society, as well as the benefits. So I think over the next 5-10 years, we're going to see a much more balancing out. Right now, everyone's about the hype and about this is the benefits, but we're going to see this emerging very quickly, sort of dark underbelly of what goes on. Thank you ever so much. I want to say thank you very much to the panelists who joined me up here today. Thank you, guys. Thank you. Wonderful. Yes.